All right. Now, often I'm kind of what's like chairing these rounds, and I'm letting people in as they kind of join. But because I'm doing that for myself today, I might just be a little bit distracted. So sorry, everybody. So just jump in and share my screen with you so you guys can see the cases that I'm going to be showing you. Right. Now, I also apologise for the noise, background noise at my place. There's builders here, so if anybody's having trouble hearing, just let me know and I'll try and I don't know what I can do about it. Sorry. All right. All right, so our objective today is fine-tuning diabetes. So not so much diagnosing at all, but we're just going to be looking at the different kind of forms that diabetes presents in different species, and what we can do to manage things. So we will go through initially some initial presentations and blood tests, and then we'll move on to different blood glucose curves and stuff. All right, so I'm going to start with Harry, who is one of my frequent flyers, and Jen, you might be familiar with Harry Malone. Yes. So Harry Malone is a 10-year-old male-neutered ragdoll who presented to me for a recheck for his IMHA, immune-mediated hemolytic anemia, who he had been diagnosed with 4 weeks before and had been started on prednisolone for. I did a blood test, and we did the CBC, and his IMHA was responding to his medication. He was more stable, and I was happy with that side of things. And I almost hadn't run biochem, but I thought I'll just check him out because he had been very unwell and had several transfusions while he was hospitalised with us. So I did the biochem, and I got these results. So, first question. We've got a cat who's been hospitalised with several transfusions a few weeks earlier and has represented for a recheck. And we've got a really quite mild hyperglycemia. How much do you read into this? I mean, this is something we see all the time, right?
Yeah.
All the time. And I looked into this, so what is the kind of threshold for stress-induced hyperglycemia in cats? Not for this case specifically, but several times when I thought, could it be, couldn't it be? And the reported threshold for stress-induced hyperglycemia is 36 millimoles per litre. Mm-hmm. So you really can't differentiate diabetes from stress-induced hyperglycemia based on hyperglycemia and biochemistry. You've got to look at the whole picture. So then moving on to other hints that we might get in our biochem, what else can you see there? Question 2 is a hint.
Yeah, ALT.
Yeah. ALT, exactly, yeah. And why is ALT so significant in a cat when we're trying to differentiate between diabetes and stress-induced hypoglycemia?
He's been on corticosteroids, hasn't he?
He has, yep.
Would it be evidence of gluconeogenesis or ketosis potentially?
Potentially, and I think it's probably those two mechanisms shouldn't usually call it an ALT, but you're right in it. It is a sign of how diabetes impacts the liver.
Yeah.
And the main thing is actually lipid storage. So we get fatty liver in diabetic patients, and they tend to get an elevated ALT. The other reasons why Harry in particular might have an elevated ALT is that he was recently anemic. There might be problems with hypoperfusion to his liver. And he's also on corticosteroids, as Jeff mentioned. So he's got a few excuses to have an elevated ALT. So I'm certainly still not convinced, just based on the information we have so far, as to whether Harry is diabetic or not. So question 3, what other things can we look for, both history, physical exam, and further testing? So let's start with history. what could the owner tell us that might make us think this is a more chronic hypoglycemia than just a stress-induced one?
Your water
It's a bit
consumption.
tricky, isn't it? Yeah.
Is it difficult because he's on Preds as well, as far as probably,
Absolutely, yeah.
polyuria and that sort of thing are concerned. So, yeah.
Absolutely, really, really difficult. And a lot of the textbooks say that cats on Pred aren't polyuric and polydipsic, and I don't think that's true in my clinical experience. And I've yet to meet anybody that actually agrees with that statement. Most cats will drink more on prednisolone and eat more on prednisolone than they would off prednisolone. So I agree. Difficult to tell based on a polyuria polydipsia history. What else?
Fructosamine.
Beg your pardon?
Fructosamine could give you a picture over the last week.
Yeah, absolutely. So
Okay.
further testing we might do. Fructosamine for sure. So fructosamine gives us an average of the glucose over the previous week, which helps us to know whether we've got a persistent hypoglycemia, so whether glucose is on average high or whether the glucose was only high very short term. So I think that's a really good point to raise when we're differentiating stress-induced hypoglycemia versus diabetes. Is stress-induced hypoglycemia is caused by an adrenaline surge. Adrenaline blocks the effect of insulin, which means you get a sudden spike in glucose, which should last no longer than half an hour. So your fructosamine in a cat with stress-induced hypoglycemia that's stressed from your visit should be normal. A cat that's stressed because of chronic illness, however, would have an elevated fructosamine. Does that make sense?
Yeah.
So a cat that's, for example, got IMHA, been hospitalised recently, all of the things that Harry's had, is going to have not just adrenaline surge, but they're also going to have cortisol, increased cortisol in the system, exogenous and endogenous. They're going to have increased growth hormone and increased insulin resistance because of the systemic inflammatory disease. So he's got a lot of excuses to be hypoglycemic chronically. So his fructosamine, all of those things predisposed to diabetes, which is actually chronic hypoglycemia. Fructosamine may be a little bit elevated, but it's probably not enough for me to make a diagnosis on. Are there any other things on physical examination we could look at?
Weight loss, but again, if it's been sick for weeks, then you're probably going to have weight loss anyway.
Exactly. And that's actually exactly what I was looking for. Harry had gained, at this point, 300 grams from when he'd been discharged from hospital. So to me, beg your pardon?
Due to the Preds, probably.
Exactly. Yeah, exactly. So Harry, he was so unwell, he didn't eat for a week, so he lost a lot of weight in hospital. But a cat that's become diabetic in response to its prednisolone will be unable, they'll have malutilization of their energy. So they'll be unable to gain weight, whereas Harry had gained 300 grams. So to me, at that point, I was quite unconvinced of him being diabetic. He was definitely, he may have had an mild insulin deficiency, but he wasn't showing clinical signs of diabetes at that point. What other testing should we do in any cat with hypoglycemia? We've done biopsy, hematol.
Would insulin levels help at all?
Insulin levels vary so much because it's such a short-acting hormone that it's really hard to catch insulin at a significant level when you're trying to diagnose a hypoinsulinemia. And in cats, they're so interesting because they might have a completely normal insulin level and have peripheral insulin resistance. And so your insulin might be normal and might tell you very little. And certainly in hyperglycemia, you should have normal insulin levels, but it would be rare to be able to diagnose a hypoinsulinemia.
For ketones and such in the urine. And
excellent. So urinalysis, that's what I'm after. So what is the threshold for excretion of glucose into the urine in a cat? Does anyone know?
15.
15, yeah.
Good. Yeah.
That's a guess. That's a guess.
Yeah.
In cats, 12 to 16, and in dogs, closer to 12, but somewhere in that range. It actually varies patient to patient. Now, the interesting thing about urine, so say you've got stress-induced hypoglycemia and the cat's just stressed because of handling and they don't have chronic illness. So, for example, if you've done a pre-GA profile in an otherwise well cat that's having a dental and you get a hypoglycemia, the glucose that's in the urine will be the average of the glucose excreted over the previous however many hours since it last urinated. Does that make sense? So say it urinated 4 hours before presenting to you and having its blood tests, and then you've got this urine in its bladder. If you've got no glucose in the urine and a hyperglycemia, then it has to just be that sort of 3-minute adrenaline surge, high hyperglycemia associated with being restrained, as opposed to a persistent hyperglycemia. So in Harry, we did do urinalysis. He was hypostenuric or isostenuric, as you'd expect on prednisolone. He did have glycosuria, so 2+ on a dipstick. He did have a moderately elevated fructosamine, but he had no weight loss and reportedly no PU, PD, PP. And I can't tell you how attentive this owner is. This cat shares her glass of water beside her bed, and she measures how much she drinks in every given day from this glass of water. And so this cat's got access to 250 mils of water, and it wasn't getting through even that amount in a day. So she was quite sure he wasn't polydipsic despite his prednisolone as well. So in this cat, on its prednisolone, with all of these good excuses for being hypoglycemic, do you treat this cat, or how do you go about monitoring him?
Check the urine for any signs of urinary tract infection, and then possibly consider diet as a first way of managing it.
Absolutely, really good idea. Yep. So looking for 2 things that Jenny mentioned there and breaking them down into why. We want a cat that's sort of pre-diabetic to be on a really low GI diet. So we don't want them to eat and then get a spike of glucose as soon as they've eaten that food. We want them to eat and then get a really flat absorption of glucose over the course of the day, so we don't get big spikes and troughs. The second thing that you mentioned is to check for evidence of urinary tract infection. And this is really important because urinary tract infection is the most common cause of systemic inflammation, which triggers insulin resistance. So we've got kind of going at Harry by 2 angles, and one is to make sure he's not getting glucose spikes, but the second is to make sure that his insulin is as effective as possible at a peripheral level, so decreasing insulin resistance by treating an obvious cause of inflammation in his system. Does that all make sense? I hope so. A lot of silence. Does that make sense?
I think so.
Okay.
Yes.
So because cats get this insulin resistance, and insulin resistance is caused by a whole number of things. So hormones can cause it, like cortisol. And the 3 hormones that cause insulin resistance are adrenaline, cortisol, and growth hormone. So we've got the 3 of them. So any disorder, which means you've got an increase in those, will cause insulin resistance. But by far more commonly, what we see is systemic inflammation causing insulin resistance. And that in cats, most commonly urinary tract infections, probably second most commonly pancreatitis. Pancreatitis in cats is much harder to diagnose. Therefore, I'd look for a urinary tract infection, and if there was one, I'd treat that. If there wasn't one, I'd try and work on diet as my main sort of medical management. But I certainly wouldn't be starting Harry on insulin at a fairly mild hypoglycemia with no clinical signs of diabetes.
And do you mean a diet for pancreatitis or a diet for the diabetes?
Sorry, diet for diabetes. So what we're talking about, Bron, is, sorry, Bron's just joined us. Harry is a cat that's just been started on pred for his IMHA, and he just had a mild hypoglycemia on blood tests a month down the track. So we're trying to look at ways which we could minimize his risk of progressing to full-blown diabetes and try and manage him without insulin. And we're talking about the impact that diet has on blood glucose over the day. So going for a low GI diabetic food. All right, is everyone happy with that case? Is everybody happy to move on?
Mhm.
Yeah, good.
Yeah.
Thanks, guys. Okay, our next patient is Russell. I love his name. Russell's a 10-year-old malnourished dachshund who presented to us, collapsed very unwell, 15% dehydrated, just so crispy, with a 1-month history of quite acute onset polyuria and polydipsia. And then more recently, and actually, sorry, I should say polyphagia as well. He had a really classic kind of history of 1 month since onset of diabetes. And then more recently, off his food, stopped drinking very much and had a 2-day history of vomiting. So he presented to our critical care service very unwell. And we ran a blood gas on him, which obviously includes the pH of his blood and his electrolytes and the other sort of factors that contribute to pH. So I'm not going to quiz you on blood gas analysis because that's probably beyond the scope of our diabetes talk. But I will just point out the parts that are relevant. Can everybody see my mouse cursor?
Yes.
Yep.
Good. Okay, so first point I want to talk about is the pH. So pH, acidemic or alkalemic?
Acidemic.
Acidemic.
Good, excellent. What causes acidosis in diabetes?
Ketones.
Great, excellent.
Mm.
So ketones are acid. So if you've got increased ketones in circulation, you will have decreased pH. What causes acidosis in profound dehydration?
Lactate.
Excellent. So we've got 2 reasons for Russell to potentially be acidemic at this point. The next thing I wanted to talk about is the potassium. Why is the potassium low?
Maybe because he's still making some insulin and it's pushing the potassium into the cells.
Potentially. This is a kind of, I guess, a bigger question, and it's something that really interests medicine specialists and not so much everybody else. So if this is really boring, tell me just we should move on. But essentially, potassium follows water in terms of excretion. So at the level of the kidneys, if you've got a patient that's hyperglycemic and Russell's blood glucose at admission was 26.1, so quite hyperglycemic, that glucose is going to pull water into the renal tubules with it, and it's going to suck all the water out of Russell, even though he's already catastrophically dehydrated, because the osmotic pressure of the glucose is just going to draw all the water in. Because you've got more water flowing through the tubules, it has to flow faster through the tubules than it would normally. Potassium resorption as it moves through the kidneys is time dependent. It relies on the potassium being in the tubules for enough time to bind and be actively reabsorbed. So if you've got fluid moving through the tubules really fast, you get potassium washout with it. So most diabetics who are polyuric, which is any diabetic that's polycontrolled, will get increased potassium losses through their urine just because they can't reabsorb it with the rate that it's being excreted.
That is really awesome. It's not boring.
Okay. Thanks, Bron.
Agreed.
It's also really complicated to explain without a diagram, so hopefully that worked.
Yeah, makes sense.
Good. Excellent. So we've got increased potassium losses. What other mechanism might we have of a hypokalemia in an anorexic dog over the 2 days?
Not eating.
Sorry, not eating.
Intake.
Decrease intake. Perfect. And what about the vomiting? What impact will that have on potassium? Has anybody ever had a dog with a pyloric outflow obstruction? Jenny, I know you have.
Yeah.
Yep. So potassium is low in dogs that have essentially gastric ileus or chronic vomiting. And it's to do with the loss of hydrogen in the stomach. And I won't go into too much detail about that. But potassium is consistently low with vomiting dogs. So we've got decreased intact vomiting and increased losses of potassium. So really he didn't stand a chance. But at a cellular level, when you've got a high glucose level, you should actually have a high potassium level. So if you've got an insulin deficiency, insulin is the key for glucose and potassium to access cells. So,
Anna, if you wouldn't mind just perhaps explaining a bit more about why the potassium's low with the upper GI vomiting, because I went over paradoxical aciduria with the students this week, and there's 2 of them listening.
oh yeah. Oh my gosh, Jeff, I might actually have to get back to you on that.
Okay, that's right. It's a question with notice.
Yeah. I might just send out, do a little amendment and send it out in the email. I would have to review the proton pump anatomy because it's to do with the HK pump on the basal membrane of the G cells in the stomach.
Right, thanks.
Sorry.
Yeah, that's a good start.
Okay. It's at a cellular level in the stomach. Okay. So if we now sort of bench potassium for a little while, because we are going to go back to it on the next page. If we look at the urinalysis here, can we say that Russell has diabetic ketoacidosis?
Certainly looks like.
Not on the urine. Are you talking about just on the urine or on the?
Sorry,
Oh.
whole picture, but just taking into account that we do have ketones present in the urine.
Oh,
We've got a hyperglycemia and we have an acidemia. Is that enough?
I think it is. 'Cause you've,
I would think so.
I think it's a slam dunk.
Yeah.
So this is exactly what I'm looking for. And often what we see, surprisingly often what we see, is that there is a metabolic acidosis, but the dogs have compensated for it. And the pH is actually quite often normal in these dogs before they get profoundly dehydrated. So in Russell, he really showed us that he was a proper DKA and made a really clear-cut diagnosis for us. So he is a dog with DKA. He is an unstable diabetic with no prior history of insulin. What are we going to treat him with?
You're going to rehydrate him.
Excellent.
Fluids.
Exactly what I'm going to do first. Yeah. So he needs fluids more than anything else. When we've got any dog with hyperglycemia, they should have a low sodium. Actually, I'm going to bench that idea for just a second. Because my question 3 is we're going to rehydrate him, which is going to do what to his potassium level?
Drop it even lower.
Up it further.
Exactly, unless we...
Supplement.
Excellent, good. So we're going to supplement him with potassium and we're going to rehydrate him. And then we're going to give him some insulin. What's going to happen to his potassium after he has insulin?
It's going to drop again.
Yeah.
It will be taken up by the cell.
Exactly right. So as that glucose heads into the cells, it's going to take potassium with it. So if we didn't supplement potassium in our initial replacement, he's going to run really low really quickly. So really important that these patients with DKA, we are often doing electrolyte levels every 2 to 4 hours in these guys, depending on how unstable they are, because of how quickly they can become potassium deficient.
Anna, if we could just backtrack slightly, what sort of fluid would you use to rehydrate him?
There's not really consensus on this. I tend to use Plasma-Lyte because it's the least acidic of all of the replacement fluids. So Hartmann's is my next choice if plasma light's not available, and then sodium chloride.
Right. There's potassium in plasma light, I think, isn't there?
There's a little bit, only 5,
Oh,
but
same as Hartmann's.
we actually often are a bit spoiled because our critical care team get a bit fancy with their potassium, and they tend to run the potassium as a separate CRI. So we can titrate that. You know, normally you spike a bag for the stable patients because you don't have to change the level too often. But if we were, you know, doing blood tests every 2 hours and adjusting the potassium every 2 hours in the bag, you can't obviously take it away once it's in the bag. You've got to replace the whole bag. So we usually just run it as a CRI based on the requirement.
Right. That's a good idea.
Yeah, it works quite well. I mean, we've got so many syringe pumps and things, and it's so easy to just put it in a side port of the line and just make sure that we're able to titrate it a bit more closely.
Anna, can I just ask another question too, going back yet another step?
Yeah.
The comment about diagnosing ketoacidosis, because we don't have a blood gas machine.
Yeah.
If I had a dog like that with ketones like that in the urine, I would be pretty confident that it's ketoacidotic, wouldn't I? Yes.
Yeah, absolutely. Yeah.
Yeah.
So this is semantics more than anything else. Acidosis is the process of having increased acids in the blood. It doesn't actually mean that the pH is acidic. Acidemia is an acidic pH. So we can say that this patient has diabetic ketoacidosis because it has ketones, which is the process of having an increased acid in its blood. So it's technically a true statement, but what we tend to say clinically and what the textbooks refer to is a non-acidemic ketotic patient, diabetic ketotic, or an acidemic diabetic ketotic. And the only difference is the way that we treat it, is in that we'd aggressively rehydrate before we'd focus on the glucose, whereas if they don't have an acid pH, then we'd probably do insulin a little bit earlier. But yes, if you don't have a pH meter, then you treat them all with fluids and then insulin.
Yeah, so, yeah.
Exactly. All right, so I think we've answered all our questions on this page. We'll move on to Russell 24 hours later. We've got pH gone from 7.25 up to 7.3. We've got bicarb improved. It was 10.3 previously, gone up to 15.4. Our potassium is fairly stable considering how much we've shifted it. So it was 3.2 yesterday, it's down to 3.1, but we would have adjusted that in response to this blood test. And today the big difference is that our sodium is now low. Why is sodium low in this patient?
I can't remember the proper reason, but it could be that he's been hypoglycemic for a while, and to maintain his osmolarity in his blood, he was ditching sodium, and he's not hypoglycemic anymore. And now the sodium is low as he hasn't got it back from his food yet.
Yeah, good. And if you actually look down the bottom, he is still hypoglycemic. We've done a bad job with our insulin 24 hours down the track. So he's still sitting at 24. Every time you've got a blood glucose over 14, your sodium, so glucose goes up by 1, sodium goes down by 2. Glucose goes up by 1, sodium goes down by 2. Actually, I'm going to have to check that. It might be the other way around. Anyway, there's an inverse. There's a 2-1 ratio somewhere there. But essentially, there's an inverse relationship between glucose and sodium, which is essentially to maintain osmolality. I'm just letting someone else into our session. So sodium will go down every time glucose will go up. So if you've got a patient who comes into you with a normal or high sodium and a glucose over 25, you know that they are so dehydrated, because their sodium should always be low. If they've got any more fluid to draw on, they will draw fluid into their vascular space to dilute out that osmolality. And when they run out of interstitial and intracellular fluid to draw on, their sodium starts to climb up back into the high normal range to the high range. And once that happens, if you look at this formula on the right here, which I'm not going to make you do properly, but if you've got, essentially, we've got to come up with a number between 290 and 310. And if we've got high sodium and high glucose, urea is such a small number normally that it doesn't contribute too much. The big contributors to osmolarity are sodium and glucose. If both of those are high, we're going to tip over that normal acceptable range really quickly. If glucose is high, sodium should be low. If sodium is high, glucose should be low. They always balance each other out. And the only situation where the body cannot balance it out is if it doesn't have, if they're feeling too unwell to drink water. So say they're really acidemic, they're decreased mentation, they're nauseous, they're not drinking water, they've got increased losses, they've lost all the interstitial and intracellular water, and they can't dilute out their sodium themselves. So beware the high or normal sodium in hyperglycemic patients. It's a really bad sign. And it's actually, high sodium is one of the biggest predictors of mortality in DKA. The UA for today, we always run serial urinalyses in our DKA patients because our whole objective is to help them to process their ketones. To do that, you need to be giving them insulin. So you need to let glucose into their cells to switch their cells back onto running on glucose rather than running on fat. So what we do with our DKA is give them fluids, give them insulin, watch their glucose track down to under 15. And as soon as it gets to under 15, we spike their bag with glucose. So this is what we're seeing with the blood glucose spiking again 24 hours down the track. We've given them insulin, we've drifted that glucose down, and we've spiked the bag with glucose and sent it back up again. And this, then we give more insulin and we bring it back down again, and then we increase the glucose again. So this cycle of pushing the glucose up and treating it with insulin essentially increases the turnover of glucose into the cells and the cell's utilization of glucose for energy, which allows them to process and excrete those ketones. Because if those cells are deficient of glucose even for a second, they'll produce more ketones and it will exacerbate the condition. Okay, so is everybody happy with Russell? Yeah.
Yeah.
Excellent. Is everybody happy to move on to glucose curve? So our more sort of chronic management of diabetes?
Yep.
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 Okay. Right. So I think glucose curves are, I think everyone gets a little bit sort of, tries to overinterpret them because there is so much variation in the way that glucose is processed in either a hospital situation or a sort of stress situation relative to what's actually happening at home. And it's actually really, really hard to fine tune your diabetics doing in-clinic glucose curves. Is that everybody else's experience?
Yeah.
Yeah.
Mm-hmm.
And I think all of us have had the experience of doing an in-clinic glucose curve, changing an insulin dose, and it having a negative clinical impact on the patient. So potentially they become hypoglycemic despite in clinic it looking like them needing a lot more insulin, and vice versa. So dropping an insulin dose and having them persistently hypoglycemic the 2 weeks later when you check them. So glucose curves are just fraught with danger as far as interpreting and making big changes in insulin on one-off curves. So we are more and more just using the little glucose buttons, the Freestyle Libras. Is everybody using them?
Yeah.
Yep.
Yeah. Yeah, super. They just give us so much more accurate information on what's going on at home, and particularly in cats where their glucose curves there is no relationship between the glucose curve in hospital and what's happening at home. It's just complete random number generation exercise essentially. And once you've got a way of doing a glucose curve that isn't impacted too much by stress hormones and things like that, is kind of as reflective as the dog or cat's normal day at home, you can then start to interpret it accurately. And there's really only 5 possibilities for your curve. First possibility is that it's a perfect curve. This is the curve that is shown on the Kensington website as a perfect curve, and I actually disagree with it. I like my curves to start at 15, go down to 5, and then come back up to 15. The goal, according to the endocrine textbook, is to maintain the blood glucose between 4 and 15 millimoles per litre for the duration of the day, with the average being around 10.
And that's dog or cat, right?
It's actually both.
Yeah, okay.
Yeah. So the curves tend to be different between dogs and cats, and we'll talk about those as we go through the case examples. But on average, you want glucose being around 10. Okay, so first possible outcome of the glucose curve is that it's a perfect curve and you don't have to change anything. Second is that you might be getting an insulin overdose. So we're seeing hypoglycemia. Third is that you might have an insulin underdose, in which case you need to increase the dose. Fourth is that your insulin choice might not be acting for long enough, or might have the wrong duration. So it might be either too long, too short, or too sharp a curve. It's the wrong curve for that patient. The inadequate insulin duration of action, or your insulin's not working. And the 2 possibilities within the insulin being ineffective option is that either the owners aren't administering it well, or there's peripheral insulin resistance. The insulin you're putting in is just not able to have an effect on the cells. But keeping those in mind, we'll now move on to the cases. And we'll start with Rosie, who had, I think she's a 12-year-old, I forgot to put a signal here, a 12-year-old female neutered cavoodle, who had diabetes diagnosed 5 months ago and is just poorly controlled. She's only about 7 kilos, and she'd been on CAN insulin 5 units BID. And the owner found that when she fed, she's monitoring a lot obsessively at home with the Freestyle Libre. And she found that when she fed diabetic food, she got much more of a spike in blood glucose immediately after eating, as opposed to when she fed chicken only, where the glucose was more stable. So on every one of these graphs, we've got a perfect curve, my perfect curve, not CAN insulin's perfect curve. And then we've got the patient. So my perfect curve is always going to be light blue. So Rosie, you can see, starts at around about 21. And then, so she's dosed and fed at the same time at 7. And immediately after eating an insulin, her glucose starts to dip. So we don't get a postprandial spike in glucose, which is more common while we wait for the insulin to kick in. So she eats and gets insulin, it dives straight down. By 10 o'clock, we've reached our nadir. And by 1 o'clock, we're back to where we started, and we're escaping over the whole rest of the day. So when we've got a curve like this is coming down to 4 down the bottom here. Can we increase our insulin dose? Is this an insulin underdose?
No.
No, I agree. I'd be really worried about a hypoglycemic episode if we went any higher in insulin dose. Should we decrease our insulin dose?
It might be
No.
Is it a Samogi at all? Or
Oh, sorry. Go
could
ahead,
it be a
Raina.
Samogi type effect?
Well, she had one of those Freestyle Libras on, and it's just not getting low enough.
Low enough, yeah.
To trigger a Samogi effect.
Mm.
What about diet? What can we do with diet in this dog?
Probably feed her a bit later, so that the sugar from the food hits when the maximum insulin effect is.
Yeah. And what do you think of the diet choice here?
Not balanced.
Well, definitely not balanced, absolutely. But as far as impact on glucose, is it a low GI food diet or a high GI diet?
No,
Sounds a low GI.
Very, yeah, absolutely. There's no carbohydrate in here at all, really. Very little carbohydrate in just straight chicken breast. So there's a couple of things that we did with her. Does anybody want to discuss that curve more, or are you happy to go ahead with what?
What about the length of effect of the insulin? Is it possible that it's quite a high dose, but then it's not lasting long enough?
Absolutely. So I think if you've got escape to the normal level, like more than 3 hours before the insulin's due, it's not lasting long enough. So she's on caninsulin, and caninsulin is a mixed insulin, which means it's got 70% long-acting insulin in it and 30% short-acting insulin. So in her, that short-acting insulin is the part that's having this effect. So for her, she seems much more sensitive to the short-acting component of it, and there's just not enough long-acting component in this insulin for her if we want to feed that diet, if we want to stick with chicken alone. Ona definitely wants to stick with chicken alone. She will not be convinced that the dog needs anything other than chicken.
But it certainly does seem to be effective initially, doesn't it? I mean,
Absolutely. This dog's sensitive to insulin. I think we can safely say that there's no insulin resistance or minimal insulin resistance in this dog. She's sensitive to insulin. It's just not lasting long enough.
Right, so the type of insulin is really relative to the diet they're feeding.
Absolutely.
Oh, I never realized that so much.
Yeah. Yeah. So you can control glucose with diet and insulin, and those two factors are so important. We speak to a lot of owners for kind of optimization of diabetic management, and they're feeding something different in the morning and in the evening. And it can be really hard to stabilize diabetes when they're eating something that causes a huge glucose spike in the morning, and then their glucose drops to nothing. And then they're feeding just chicken at night, and their glucose is staying the same all day in response to the chicken. So consistency is so important, and you can modify insulin or you can modify diet, but I wouldn't do both things at the same time. Does anyone want to know what we did with her?
Sorry?
Do you want to know what we did with her?
Yes.
Yes.
Yeah.
I switched her onto insulin called Detamir, or Levemir is the trade name, which is an exclusively long-acting insulin. Glargine would have been another good choice for her, being a long-acting insulin. Detamir is a really potent insulin, and I put her on 1 unit and her curve went completely flat. And it sat at 10, and it's the most perfect glucose curve I've ever seen. But now I can't change her diet.
Well, she's happy with that, though.
She's really happy with that, unfortunately. So the owner won that round, but the dog is really well controlled on just an exclusively long-acting insulin because she's so insulin sensitive.
Are you using that twice daily still?
Twice daily, yep.
Was changing the timing of her meal an option in this one?
Potentially.
And remaining with caninsulin?
Except the owner would have had to, like, impact on the owner would have been huge, because she was a grandmother who did childcare, so she'd have to drive across Sydney by 7 o'clock to take over from the daughter's kids, and she would have had to get up at 4 a.m. to feed earlier and stuff. Yeah, so the biggest factor, if you look at the client, the impact, well, what the client's main concerns are in diabetics, it is the impact on the owner more than the health of the pet that will mean that owners elect euthanasia. So if we can sort of factor that in with all of the decisions that we're making for our patients and try and treat these patients in a sustainable way with the owner's routines and stuff, the dogs will live longer. They won't be euthanized.
Also, feeding this one earlier, would that just increase the pre-insulin level to way too high anyway?
Potentially, yeah. So I actually
it's already quite high there at the beginning.
Yeah, I probably would have insulined here and fed here, which would also insulin here and fed here. So it just flattened out that curve a little bit. But then, yeah, again, doing things kind of 2 hours apart is just such a huge impact unless people are living really closely with their dogs. All right, so next glucose curve is Charlie. Charlie is a 9-year-old male-neutered domestic long hair who's been diabetic long term, and all of a sudden he developed essentially loss of control, PUPD, weight loss, despite having been on 3 units of glargine BID for a really long time. So again, my perfect curve in light blue on here. And then we've got Charlie's curve. And this is on a Freestyle Libre. So if this happened in hospital, I would think this is a really stressed cat and he got a little adrenaline surge here and the cortisol's kicking in, and this is not an accurate curve. But this is at home a couple of days into having a Freestyle on. So, you know, a couple of days after his vet visit, and he was really comfortable and happy. And it's consistent. The insulin just doesn't seem to be doing anything. So what do you think of this curve?
There's either not enough insulin, or the insulin is not active, or there's a insulin resistance.
Good. What's the other possibility?
Owner compliance.
Absolutely. Yeah. So did they leave the insulin out? Have they all of a sudden been getting their 4-year-old to do the injections? There's all these strange things that owners do that they don't think will be problems until you start asking them questions and they say, oh, yes. So in this case, I'd have to say the insulin's not working at all. I think insufficient insulin is probably unlikely, because even if the dose was too, like his insulin dose was too low, we should see a dip in the curve, not a rise in the curve over the course of the day. So his insulin's not working at all. So I quizzed the owner. There was absolutely no change in management. They tried a new insulin bottle and it made no difference whatsoever. I watched them administer the insulin myself and was really happy with their technique and that the insulin had gotten into the cat. What do we do next?
Urinalysis and culture.
Yeah.
Perfect.
Yeah.
Absolutely. Yeah. Now he's a male cat. What are the risks of a male cat having bacterial cystitis?
Blockage.
Pretty low.
Pretty low, except in diabetics.
Right.
And except in patients over 9. So we used to think, so, you know, all of those fluted studies and stuff said that less than 0.3% of cats male neutered cats have infections. There's no point culturing the fluted cats when they come in if they're male. I disagree with that, particularly in diabetics. And now that we're seeing more sort of older cats with fluted, they haven't sort of been euthanized early on because we're getting better at managing them, they actually often have infections. It's not that uncommon in male cats. So I always would culture urine for sure, particularly if the UA suggested presence of inflammation in the urinary tract. And then urine culture and urinalysis comes back negative. What next?
For pancreatitis?
Yeah, that's exactly what it was. Yeah. So how do we diagnose pancreatitis in cats?
Ultrasound.
Ultrasound?
Good. Yeah. And how sensitive is ultrasound for diagnosis in cats?
30%, I'm going to guess.
It's not very good. So it's around about 70% with acute necrotizing pancreatitis, but the vast majority of cats have chronic pancreatitis, in which case we see some subtle ultrasound changes, such as slightly increased echogenicity, slightly undulating border of the pancreas, slightly dilated pancreatic duct, but it has to be quite bad or quite chronic for us to get those kind of changes of fibrosis and dilation and stuff like that. So it can be really hard to diagnose ultrasonographically. What other ways do we have of assessing pancreas in cats?
Feline pancreatic lipase.
Good. Yeah, exactly. So there's problems with all of the pancreatic lipase tests, but I think it's a really good kind of supportive, you know, when you're forming a whole picture, really good supportive bit of information to have. So Charlie became very difficult to manage because pancreatitis we can't treat very well. We treat symptomatically. It's not diet related in cats. So it's just really pain management, nausea management. And as a result of the inflammation in his pancreas, he had insulin resistance. And what we had to do to offset that is use pretty high doses of insulin, and he got up to 7 units of glycine BID. And his curve came down. It stayed pretty flat, but overall it was sitting at a lower average. Now, the risk with doing that is obviously if his inflammation resolves, if his pancreatitis goes away, pancreas probably isn't going to go away. If his pancreatitis goes away, all of a sudden his insulin requirement is going to drop through the floor and he's going to be at risk of a hypo. So just talking to the owners about how closely they live with him, whether they're, you know, out for 12 hours at a time, 5 days a week, which would leave him pretty vulnerable to having a pretty serious hypo unobserved. That would really guide how aggressive I was likely to be with my insulin dose in a case like this. Everybody happy with that? And I should put in there, 40% of diabetic cats have pancreatitis on histology. It's a huge percentage. So they've often got some degree of inflammation in their system and decreased insulin sensitivity.
Is that why some cats go into remission? The pancreatitis settles?
It's a really good point, actually. Yeah.
I
I don't know.
Some cats on Lantus that do go into remission.
Absolutely. Yeah.
Yeah.
It's potentially one of the factors. I'm not sure that they'd have to do histo before and after diagnosis to be able to say that that's why, but I'm sure that contributes to them going into and coming out of remission potentially. Last case I'm going to talk about, we've only got about another 5 minutes, but if everybody's happy to kind of get through as much as we can get through. Rudy is a 6-year-old female entire staffy. He's a really well, is a really well dog. She's quite sort of young, sprightly, healthy, energetic. She'd just been PUPD, losing a little bit of weight, and was started on a pretty low dose of caninsulin, or I guess it's a very reasonable starting dose of caninsulin. And you can see my perfect curve down here. What do you think about Rudy's curve?
Fairly perfect, but too high.
Exactly, yeah. So she's responding to insulin. We get a dip, and we get it coming up again to about the same level as we started at. So are we going to say, what's our diagnosis?
An insulin underdose.
Absolutely, yeah. So we're just going to increase her insulin, see how she goes. 3 months later, on a fifth of the dose that she started on, she's having hypos pretty regularly. This is our perfect curve. And this is Rudy, who's coming right down to 2 pretty much on a daily basis on a really low dose of caninsulin. What's our diagnosis here?
Was she on heat?
Oh, such a good question, Jeff. So Jeff has asked the question of the day. The signalment in this case is really important. She was not on heat. This is 3 weeks after. No, sorry, beg your pardon. She's just gone into heat, yes. So do you want me to expand on Jeff's comment?
The diestrus thing.
Yes, it's the diestrus thing. What is diestrus? So this dog, I think we can say from this curve that we've got an insulin overdose. And given what a low dose of caninsulin she's on, you'd have to say that she's gone into remission based on this curve. So what I do in this situation is remove the insulin and see what her curve looked like over the next couple of days.
And then remove her ovaries and uterus.
That is the next step, exactly. So if anybody's as bad at repro as me, diestrus is the long part of the cycle between estrus. So it lasts for around about 70 days. So it's the majority of her life is she's in diestrus. During diestrus, there's higher levels of growth hormone in dogs, entire dogs. And if we remember that the 3 hormones that cause insulin resistance are cortisol, adrenaline, and growth hormone, she's developing diabetes when she's got high levels of growth hormone as a result of her peripheral insulin resistance. So she just can't produce enough insulin herself to overcome her resistance. So what we added to her system is enough to get her over the line to be a fairly functional dog, until she gets into estrus, where her growth hormone levels drop and her insulin resistance goes straight back to normal. So if we desex her, her growth hormone level is stable and her body will compensate and produce the right amount of insulin. So it's one of the only real times we see dogs going into remission with diabetes. All right. So Jeff's already answered my question. Are there any questions, Signament?
Jeff, you've seen more entire dogs than me.
Yeah, absolutely. I thought this was so cool.
God,
Like
it's
the entire diabetic I've ever seen.
oh, that subject is a real bitch, that one.
Yeah.
Yeah.
All right. We've made it through our hour. Well done, everybody. Thanks so much for getting involved in those cases as well. That makes such a difference. This makes it way more fun for me.
Thank you.
Awesome. Thank you, Anna.
Yeah, great.
Thanks, Anna.
No worries.
Yeah, that was fun. Thank you heaps.
Excellent.
It was really excellent, Anna. May I ask a question on behalf of my students
Yes.
from last week on a not related subject?
Yeah.
With pheochromocytoma or aldosterone secreting tumours,
Mhm.
is mitotone a suitable treatment for it?
Pheochromocytoma is a tumour of the adrenal medullary cells.
Yeah.
And mitotane targets the adrenal cortical cells. So I wouldn't use it for pheo. Aldosterone secreting tumour, potentially. But we've got, as far as medical management goes, we've got spironolactone, which blocks the effects of the excess aldosterone. So clinically, if they're not going for surgery, we've got a really good treatment for that. Mitotane makes sense because it should be cytotoxic to those cells and be a kind of an alternate to surgery, but I'm not sure I've ever seen any case reports on its use.
No, I hadn't either. But I just thought it was an interesting question and I wasn't quite sure of the answer, and I thought, well, I'll ask someone who's more expert than I.
Except on repro. All right, any other questions, anyone? No? All right. All right, thanks so much, everybody. Alan,
Thank you, Anna.
no worries. Alan again on Monday night with something surgical. I'll send out an invite for that. And also, if anybody missed out in your practice, then just let them know to go to the app, to the news and resources section, and the video will be uploaded over the weekend of this.
Anna, I forgot I had a question.
Oh yeah, go.
Sorry. Liz was talking about Samorgi not being that recognised anymore, or maybe overdiagnosed. When you get a precipitous fall, can that actually cause hypoglycemia, like as opposed to just hypoglycemia? Can it cause hyperglycemia just from the rapid fall of glucose?
Yeah. Well, not so much from the fall, but anytime you get a hypoglycemic episode, the body's response to that is adrenaline, cortisol, growth hormone.
Okay.
So adrenaline's going to get it out of trouble in the next 3 minutes. Cortisol is going to get it out of trouble in the next few hours. And growth hormone is going to get it out of trouble in the next weeks.
Okay.
So if you've got,
So you have to have hypoglycemia, not just a big rapid fall.
exactly right. Yeah.
Okay.
So it has to actually dip below the body's level where
Okay.
it's.
And it sounds like it's overdiagnosed anyway. So, do you think we realise they were overdiagnosed because we're doing continuous monitoring now?
Yeah, absolutely. So I think we often were seeing these the insulin that were insufficient duration of action. And we were saying, oh, it spiked, 4 hours after we dosed it. But actually it was just that dog, for whatever reason, needs less short acting, more long acting in its insulin regime. So I don't know. I think our understanding of it has improved. The term Somogyi has gone out of fashion, but there is a counter-regulatory hormonal response to hypoglycemia. And if you've got a diabetic patient and they go hypoglycemic due to, both owners dosed it that morning or whatever it might be, they have a hypoglycemic episode, their glucose is going to be high and not interpretable for 36 hours after that episode. Potentially even longer if that hypo was prolonged. So sometimes we get double doses of insulin that are hypo for 24 hours, and then we're going to get the growth hormone kicking in as well as the cortisol and adrenaline, and that's
Right.
a sustained impact on it.
Yeah.
So hypos definitely cause hyper, but it's not as kind of short term as the Somogyi effect that we thought it was.
Okay. Thank you.
No worries.
Again. Bye.
All right. See you guys. Thanks.
Bye.
Bye.